Thank you all for being here, and welcome to the Aspen Ideas Health Forum and to this panel on reproductive health. We are so excited you're here. We are so excited to have these two incredible panelists, and I'm going to introduce them, although they really need no introduction. Dr. Chelsea Clinton. Through her work at the Clinton Global Initiative, she has made maternal health and equity a key priority. And Porchia-Albert, the founder and CEO of Ancient Song, a national birth justice organization working to eliminate Black and Latinx maternal and infant mortality and infant morbidity. Welcome to you both.
Thank you so much, Kristen.
Thank you. I'm obviously a journalist with NBC News, and this is a topic that means a lot, I think, to all three of us. So I want to start off just by getting your personal reflections. What drew you to this space to work on reproductive health? 700 women die in this country every year.
Well, last year it actually was 1,200.
Was it 1,200 last year?
More than 1,200 women died in 2021, the last year we have full data.
Which just goes to show you this is a problem that some years is getting worse, some years is stagnating. We are obviously one of the wealthiest nations on earth, and we have one of the poorest records when it comes to women dying in issues related to childbirth. So, Chelsea, you're a mom of 3.
Goodness.
Why did you want to work on this crisis?
Well, Kristen, I want to thank you and everyone here at Aspen Ideas for bringing us together this morning for the absolutely spectacular weather. Although I also have to acknowledge that Chanel and I did not experience spectacular weather when we were together in Denver last night, and our flight was canceled. So I last saw Chanel like 6 hours ago because we drove from Denver together to Aspen because we were so determined to be here.
And we should note that Chelsea also obviously has an injured foot, but none of that stopped her from being here.
Oh yes, no,
So
neither hail nor broken bones. We persist. I think, Kristen, this, has long been an issue I have felt kind of galvanized by, called to use whatever kind of resources I have to try to not only kind of raise awareness about the challenge of maternal mortality in this country, about the health equity challenge and tragedies of maternal mortality in this country. And then I became a mother, and it became all the more personal to me. I also have a number of friends who've had quite harrowing experiences. I'm very happy to share. One of my good friends from Stanford actually got out of Stanford Hospital yesterday.
Oh, wow.
A woman of color who hemorrhaged 3 times.
Oh, my gosh.
And thankfully is now home safely with her baby. But that level of kind of trepidation and fear and risk should not be as pervasive as it is in this country. And, Kristen, in your introduction, you said this is an area where sometimes it's getting worse and sometimes it's stagnating. I think I also feel so compelled kind of to do whatever we can in kind of saving the lives of expectant, birthing, and new moms in our country because we do actually know what works. Mm-hmm. A woman today is 50% more likely to die in childbirth than she was when I was born in 1980. And actually, a woman today is 3 times as likely to die in childbirth in this country than if she'd been giving birth in the year 2000. So this is an area where we actually made meaningful progress for women and for families in our country for 20 years, and then we've had a slow and steady erosion of that progress. Despite at least 80% of maternal deaths being judged to be preventable, and we know what works, and we're not doing what works. And so I hope we can talk more about what works. But when you ask me why am I in this work, it's not only kind of the fundamental ethical premise that I believe no person should die while being pregnant or delivering a baby or kind of in those first months after a baby is born. It's also because I am quite angry that we continue to ignore so much evidence about what works to save women's lives. And so I think we have to just not look away. And we have to try to bring more people into metaphorical and actual tents like this, to listen to what works, to listen to people like Chanel who are on the front lines of delivering what works, to help save women's lives.
And I think that's part of what's enraging when you hear that 80% are preventable. And it makes you ask the question, how can we not be at a place where we are saving more lives? Chanel, let me turn to you. You are a mother of 6.
I am.
Which could be a panel in and of itself. I mean, that is extraordinary. But in reading your story, you had the revelation that you wanted to be a doula after having your first child.
Yes.
So tell us about that moment and tell us what brought you to this work.
All right. So first I want to say greetings, everyone. Good morning.
Good morning.
Oh, no. Good morning.
Good morning.
Okay, that sounds a little bit better. I want to make sure you're up and you're awake and you're vibrant. As Chelsea said, we were in a car for many, many hours.
So Chanel's like, if I have that much enthusiasm on 4 hours of sleep, come on, people.
They were bonded before, but now they're really a team.
Yes, exactly. So I got into this work after my first childbirth with my son, who is going to be 15 now. And I had an amazing home birth with a beautiful home birth midwife and a doula, and my husband was there, and my family was there. And it was the most sacred and amazing experience to have your bodily autonomy centered, to have the way in which you see yourself bringing your child into the world surrounded by joy, surrounded by love and peace. And so I took a doula training when I was 7 weeks postpartum. And it was amazing. I was around midwives and healers and doulas and, folks who were in this space who really nurtured me as a mother. And being a first-time mother and not having my own mother present because she transitioned when I was 14 was, it's a moment, right? When you step into motherhood, you're looking for this guidance, you're looking for support. And having all of these women around me really transformed the way I thought about my parenting and my motherhood. And so after taking that doula training, I started to attend births, and I was completely surprised of what I saw. Seeing folks who were experiencing insurance segregation, so looking at someone who has Medicaid versus private insurance and the ways that they are segregated on different floors or don't have access to certain services, seeing the way a mother would be sitting for a prenatal visit for 4 hours to be seen for 10 minutes, to come out of the visit and not understand what just happened, to see the criminalization of Black and brown bodies at bedside, right? Through illegal drug testing, or when someone is trying to advocate for themselves, then being told, well, you have no voice and no say in this space, and then having security or police officers called on partners. And so it completely changed my framework of thinking I'm going into a space centering someone holistically, right? Going to offer comfort measures, doing aromatherapy, the things that we do. We have magic fairy dust, right? And thinking I'm going to do that and having to totally change my frame of reference into more of an advocacy stance. Right, and so I opened up my home, and about 23 people who were interested in being a part of making a change came to my home, and it started from there. And it just really started from a desire and a need to really center someone's bodily autonomy and their basic human rights to birth in a way that they should just have the right to do, right? We wake up this morning, we all woke up this morning, we're breathing, we're living, right? We're joyful, we're here, right? And that's the same way when someone is giving birth, it should be surrounded in joy. It should not be surrounded in fear. And so when we're talking about, the increase in rates of pregnancy-related complications, when we're talking about Black maternal health, what we're really talking about the ways in which Black, brown, and indigenous people are not centered within the healthcare framework, but not in society at all, right? We're missing the mark on what does it mean for me to see you, right? What does it mean for me to engage with you and see you as a human being, right? And touch that moment and say, you know what? I'm going to reflect that back at you because that's important, right? Because that's all people really want. We want to be seen, we want to be heard, and we want to know someone genuinely cares for us.
In so many of these instances, and I've done reports about this, Black women, their families, if they have passed, have said to me that they have not been heard. the rates are staggering. Black women, Native American women are 2 to 3 times more likely to die from a pregnancy-related cause than white women. And of course, we all had this horrifyingly tragic reminder in the news recently. Tori Bowie, an Olympic gold medalist, died due to complications from childbirth at her home.
By
she
herself.
was 8 months pregnant by herself.
Exactly.
Chanel, can you help us to understand how can this happen in this country right now? She apparently, based on what I have read, died of eclampsia, basically seizures from preeclampsia. How could she have been at home? How did this happen?
I mean, so I'm not a doctor, OBGYN, or a midwife, but I will say that to me, that seems like negligence on the part of her providers, right? Because
that she shouldn't have been at home. I mean, my first thought was, how on earth could she be at home?
Well, there should have been signs, right? There had to be signs, right? She's going to her prenatal appointments. Hopefully she was going on a regular basis, right? And they had to see some sort of fluctuation in, her blood pressure, maybe protein in her urine for it to get to the level in which it was. I mean, I don't know. We don't know whether she expressed what she was feeling. Like, was she experiencing dizziness? Was she lightheaded? Did she have any signs? Some people don't have any signs at all, right? And so I think it's just a tragic reminder of the ways in which Black, brown, and indigenous people can fall through the cracks when we're not taking an opportunity to really listen and to hear. And it's not always about like having an automatic response. And I think it's also understanding that we need to reframe the ways in which we are shaping reproductive healthcare access as a whole, because it's not working for anybody. It's not working for anyone, but it's especially not working for Black, brown, and indigenous women in its totality. The ways in which we go into a space and, you feel like you have to negotiate with a provider, right? You feel like you have to arm yourself before you get into a room, right? I should not have to have a conversation with someone around, this is what you're going to need to expect. If someone says this to you, well, this is your rights in childbirth. And so we have to have conversations around know your rights in birth before you can even walk through the threshold of the door to even get service, right? So think about that allostatic load that someone is now carrying. You have the social implications of racism. You have maybe financial burdens. Maybe you're, you have things going on in your life like everyone else. And now all you have to fight in your birthing process, a space that's supposed to be like holistic, it's supposed to be warm and inviting, right? When you see children come into the world, that's the most sacred thing that there is. But unfortunately, that's not what's happening.
Chelsea, we learned that 3 out of 4 of her teammates on her relay team, women of color, also struggled in childbirth, had near-death experiences. Allison Felix came forward and talked about this. What went through your mind when you heard this, and how important is it that we're sharing our stories? You opened up by talking about your friend who was in a dire circumstance in delivery. How important is it that we are sharing our stories about this?
I think it's hugely important. And yes, on our 2016 relay team, now the second fastest women's relay team in history, our gold medal winning team, 3 of the 4 members of our team have had very serious, and in the case of Tori's, tragic experiences with pregnancy. And I think that, Kristen, though, is a really kind of painful, stark, and hopefully, such a kind of dramatic data point that you can't look away, that athletic ability, underlying health status, wealth are not protective factors. If you are a wealthy, healthy Black woman, you are still far more vulnerable in this country as you are pregnant, kind of giving birth and postpartum, than if you are a low-income, not especially healthy white woman. And so to me, that certainly speaks to kind of all that Chanel was saying about her lived experience as a doula with the patients that she has and continues to care for. We do, though, know that doula accompanied birthing experiences have much better healthcare outcomes and experiential outcomes for women. And so to have a moment of kind of optimism where hopefully we're starting to do something right, there are now more than a dozen states that by the end of 2023, including here in Colorado where we are, in which Medicaid will fully cover kind of doula support throughout pregnancy, childbirth, and postpartum. And that's one of the consequences of something that was small but mighty in the American Rescue Plan. Of course, that then highlights the dozens of states who haven't kind of expanded Medicaid coverage to ensure that pregnant and birthing women in their states have access to those same services. Because having a doula, particularly if you are a Black woman, a Latinx woman, an Indigenous woman in our country, is not a nice to have. It's not a comfort or a convenience, although hopefully it is comforting and hopefully it is more convenient. It is a life-saving form of accompaniment to ensure that women are being centered, that women are being heard, that women are getting the early kind of intervention and response kind of if and when something signifies that there may be a challenge. And so, for me, Kristen, it is both the, again, kind of the anger of what we have permitted in this country, kind of for women holistically and particularly for Black, brown, and Indigenous women. It also, though, has to be kind of attention paid to where we are investing and what we know works, partly to candidly put pressure on the places where we're not yet investing in what we know works to save lives.
Yeah, and I'll pick up on that point, please, and the significance of having doulas who are accessible and also doulas of color.
Yes.
Who are listening and paying attention to the nuances.
Yeah, so I think doulas are amazing, right? We have an opportunity to really shape the course and to assist someone in affirming what it is that they want for themselves, to help them to center their bodily autonomy, and to really bring forth a joyful birthing experience. But I also want to note that doulas are not the only answer, right? And so as we're looking at this, we also need to think about building up the perinatal workforce as a whole. There are amazing midwives, some of them are here in this room right now, who are doing tremendous work to be able to center their communities in amazing and affirming ways. We have Ebony Marcel from Community of Hope, yes, in Washington, D.C., who has created a birth center where it's a one-stop shop. You come in, you're able to center yourself, you can get pharmaceutical care there, you can have the experiences that you want, and it's a touch point for the community. So not only is she an institution within a community, but she becomes an extension of that community. We need to think about building up OBGYNs of color, right? And centering them in a framework. But not just putting people of color in a space to take up space, but also affirming them while they are in those spaces as they're doing their jobs. As they see things coming up, especially within their communities that they're working in, providing responsive care mechanisms so that they can really center those communities in affirming ways. Because we also want to make sure that we're retaining those folks who are coming into those spaces. I train medical residents, and what I've noticed is that folks in their residency, they're burnt out. They're working these long hours, these enormous shifts, and they find themselves in a chokehold where they can't really give the care that they want to give based on either administrative policies or the lack of funding that is being placed within their respective institutions. And so while doulas, yes, are amazing, and I say that again, as a doula, we are not the only answer. And when we start to talk about Medicaid doula reimbursement, we really want to look to the folks who are within those communities, who are doing those works, who are active participants in the communities to really measure what does the implementation of that look like and where does the accountability come from, right? Because I'm someone who has worked on doula Medicaid reimbursement on a national level for a while now. And what I've noticed is that we'll have this wonderful policy that will come up, and then we come to in contact with these roadblocks with state agencies, right? And so it's not about just paying a doula, it's about making sure that we can sustain that workforce, right? That we're paying folks at a living wage, but we're also sustaining the community-based organizations that are there so that they can continue to do their work in an affirming way. So that's one pathway, but we also want to make sure that we broaden it out.
Well, and Kristen, can I just please pick up on something that Chanel said that I think is so important, which is that, while we are doing more, and I'm so grateful to work with Chanel as part of the New York City Birth Health Equity Initiative, because New York City is the ignominious distinction of being the biggest kind of urban metro area in the country with kind of the worst health outcomes for expectant and new Black mothers. So if you are a Black woman giving birth in New York City, you're actually 9 times more likely to die in childbirth and from postpartum complications than a white mother. And I'm thankful to the mayor's office and the New York City Health Commissioner's office for not only a willingness to be candid about that, but a real clarity around kind of what is the public sector going to do, what do we need the not-for-profit and advocacy sectors to do, what do we need the private sector to do, and to have a real plan of shared accountability toward what we're driving toward 2030, which is to cut Black maternal mortality in half, initially in Brooklyn, and then hopefully that's a blueprint to move across.
Yeah, and there's some wonderful initiatives happening in New York City, right? Just around centering that framework. So we have the New York City Citywide Doula Initiative, which is the city really taking charge and taking an initiative to pay to train. So I'm actually training all of the doulas in New York City who are part of that program to be able to work within their respective boroughs.
A guaranteed source of income.
Right, and gain a source of income, right? But then we also have wonderful folks like Kimberly Sills-Allers with the Earth app, who is also working with hospitals, right, to set a measure of accountability as well, right? So we have things going hand in hand at the same time.
Well, and I think, though, too, it would be disingenuous to not acknowledge the other forms and causes of maternal mortality in our country, particularly sitting here in Colorado, in which death by suicide, death by homicide involving a firearm are leading causes of maternal mortality in this state and in many other states. And so we unfortunately have, a rather uniquely American collision of challenges of our kind of underappreciation, decentering of women, with, I would argue, our overappreciation and centering of firearms. And we see the ways in which kind of that, those forces, coalesce in a myriad of significantly tragic ways, and also our growing inability to have kind of, I think Chanel would agree with me here, a very robust harm reduction approach to opioid and other forms of addiction, because increasingly accidental overdoses are also a leading cause of maternal mortality here in Colorado and around the country. And we know that while we have to be doing more to increase our doula and midwife workforces kind of with dignity, with purpose, with compensation, we also can't expect to render all responsibility onto our midwives and doulas. We need policymakers to be doing more, not just on Medicaid reimbursement, but more holistically, to be protecting vulnerable people in moments of real vulnerability, in which, of course, pregnancy is one of the most vulnerable experiences that any person can have.
Chelsea, I'm glad you said that, because you take me to my next point. I do want to delve into why this is happening, because this cuts across socioeconomic groups, as we are saying. We've talked about some of the causes here, but let's explore some others. Lack of access, education, systemic racism. Chelsea, for you, what are the key contributing factors, the key factors here?
I choose D, all of the above. And
that's an option.
My original home state of Arkansas has, the ignominious distinction of being the worst place to give birth now as a woman in our country. We have the highest maternal mortality rate in the country. We also have the 3rd highest infant mortality rate in the country. I think sometimes there's this real kind of comfort in complacency of like, oh, it's just all so complicated. Like, there's nothing we can do.
Right.
Like, well, no, inertia is never an excuse to not try to save someone's life, particularly as a not parenthetical aside if you're the party of family values. But also, when we know how to save women's lives, and when we know how to invest in at least beginning to ameliorate the harms of centuries of racism and gender discrimination in this country, and the over-expectation of what we expect out of Black women in this country, we know what to do. But unfortunately, in Arkansas, we are not doing that. We have discontinued Medicaid beyond the federally mandated 2 months of postpartum care. We are discontinuing investments that actually the previous Republican governor made in expanding funding for birthing centers in underserved parts of Arkansas. We are not looking to what's working in places like New York City to recruit, to train, to compensate Black and brown nurses, midwives, and doulas to be able to provide excellent care to expectant and new moms of color. And so, Kristen, what I find so infuriating, and again, I know this is at the risk of belaboring, it's like, this is not a mystery. This is a failure of political will. This is a comfort with the persistence of insidious racism and misogyny in this country. Like, this is not a mystery.
Chanel, pick up on that point. Do you agree with Chelsea, and would you add anything to that list?
Yeah, I mean, I totally agree with Chelsea. And, I would add to that, I want to take a moment to take a step back, right? And to really, Chelsea, you spoke about solutions, right? And when we have these conversations, they're always steeped in crisis and people are in danger, and looking at it from a space of critical, we're at a critical mass, right, of where we are. And yes, that's true, but then what does it mean for us to dreamscape hope? What does it mean for us to center a framework where we're really identifying and singing one another? What does it mean for within policy, we are changing the way in which we're pulling the levers and really listening to community as active stakeholders within their care? Because they know, right? You know what you need, right? And it's a matter of this indifference that I think comes up, or even maybe a lack of knowledge, right? I'm gonna give some people the benefit of the doubt, right? That there's a lack of knowledge and understanding of what it really truly means to center someone in their collective well-being. The United States is supposed to be the greatest nation. We're the most industrialized nation. But the ways in which we treat our women and birthing people is terrible, right? The ways we don't value women. We don't value children, right? We don't value parenthood and what it means to be a parent. As a mother of 6 children, I have to think about 20 million different things every single day. When my son was young, he was cute. No, he's adorable. Everybody loves him. Oh my God. Now he is going to be 15 years old. He loves to play chess. He wants to go into finance, but he's also seen as a community threat. And when we're talking about Black maternal health, and we're talking about parents of color, and we're talking about varying socioeconomic statuses, we're not just talking about us being able to birth in a healthy way. We're also talking about us being able to raise our children in healthy and safe and affirming environments.
Well, and I think, Chanel, to your point about education, right. Like, I think about this a lot. Like, I love my home state of Arkansas. I believe that people there deserve better, which is why I talk about what more could and should be done for women, for families. I think, though, to Chanel's point about giving people the benefit of the doubt, I also think about how when I was a public school student in Arkansas in the early 90s, I had age-appropriate kind of reproductive and sexual health education. Just a matter of fact, it was part of life science class. It was probably the most awkward unit that poor Mr. Johnson had. But he did. And also, there were contraceptives available, there were condoms available in the nurse's office. If I were a public school student in Arkansas today, none of that would be true. And so I do think Chanel makes an important point, which is that for people who are privileged enough to be in places and spaces like this, not only to be in this beautiful place, but to be in a community where maybe some of us know more about this issue than others, but all of us think it's important because we all chose to sit inside a tent instead of to be out in the glorious sunshine, to learn more together, kind of to be in solidarity together, to hopefully, figure out what more we could do together. I think sometimes we do not kind of have the mindfulness of how little so many people really do understand about their own bodies.
And I think it's also understanding the ripple effect that comes with that, right? How we choose to center one individual impacts a lifetime, right? We're talking about intergenerational care. We're not talking about just one episode of pregnancy, right? And so how we're choosing to center that pregnancy, how we're choosing to center that person has a long time effect, right? Because we see this as doulas, midwives, right? It comes up in the birthing experience, but it also comes up in parenting.
One of the themes when I have explored this topic is a lack of listening. And I covered a just tragic story in Atlanta. Kira Dixon Johnson and her passed away in childbirth. Her husband suing the hospital system where she died. And what he said to me is that the doctors didn't seem to be listening to her when she said she was in pain. When she said, something doesn't feel right, they said, it's going to be okay. And she said, I don't think it is. I mean, she said that. What is that? Is that systemic racism? Is that, as you have said, sometimes people are overworked and exhausted? How do you get to the root of that?
I think it's compounded, right? I think it is the fact that our infrastructure, our maternal health infrastructure as a whole, is not in a place where it needs to be. I can go to two different hospitals in the same place, right across the street from each other, and they have totally different policies on how they want to treat someone. So one, we need universal policies on maternity care. What does that look like for there to be a baseline and a standard of you need to have this, this, and this, right? But also understanding and having this reality that, but when I'm coming in, I'm speaking to you, and we're having this instead of having this transactional relationship, we're really having this interpersonal relationship where people are culturally humble and responsive to someone's care. I think that's one part. I think the part with Charles Johnson, and Charles is amazing, right? He's become this huge advocate, not just for Black maternal health, but also for Black fathers, right? And centering Black fatherhood and what it means to be a Black father in America, because he found himself in this situation where they were at a higher socioeconomic status, right? But he also is a Black man. He's a Black man in America. And he goes and he talks about his story and about the ways in which he wanted to push and say certain things, but he also knew that if he spoke up too much, he would be seen as aggressive. He would be seen as a threat. And then he could be kicked out of the hospital and then no longer be able to provide the support that his wife needed. And so that's where the racism comes in at, right? Where as a person of color, as a Black man, as a Black woman, you want to center and you want to affirm yourself, but then you're coming against the systemic oppressions of how someone is viewing you. I went and I work at a hospital, with a hospital in New York, Elmhurst Hospital, where we have engaged in a community-based doula program with them. And before we even started to do the program, the first thing I said we needed to do was we need to train every single person who comes in contact with someone who's pregnant on what does it mean to, one, have a doula, what does it mean to work from an anti-racist landscape, what does it mean to center someone in their bodily autonomy, and really center a basic human rights framework in birth. And they were like, what do you mean every person? I said, every single person. The social worker, the person who is admitting the person, the nurse, the CNA, the person that comes in is like, hey, I just want to change the garbage real quick. Can I, they need to have, education around what does it mean to be touch points in someone's life as they're navigating the system. And we don't have that right now. And so what Charles and what so many others are facing is this conundrum of, one, a healthcare system also that was never geared to treat Black, brown, and indigenous people. Let's just talk about that as a whole.
Or women.
Right, or women, right? And so when we're talking about healthcare, we're talking about the enslavement of African women, right? And then being tested on in order to advance medical sciences, right? Then you have Reconstruction era, you have Black men who can vote, and then that's taken away, right? Women still can't vote. Then you have Jim Crow era, right? Then you have the Civil Rights era, you have desegregation, but you never still taught anybody what it means to center that community. You just said, here, go into that space. So, you have years of a system that has been in place where people have been told, you are less than, right? But now I need to take care of you. But I've never talked to you about what does it mean to remove those biases, those years of traditions, because it's a tradition. It's a tradition of racism that has been put in place, and now care for a body that you were told to disdain, right? And so we need to restructure our medical education. We need to talk about the ways in which we're centering community in affirming ways. We need to come to terms with the realities of what does it mean for us to remove ourselves from transactional relationships.
We are having this. Go ahead.
I just want to say, sorry, Kristen, quickly,
please.
in that I do think it's also important to acknowledge, until 30 years ago, women were not required to be participants in clinical trials. Until just over 20 years ago, children were actually not required to be participants in pediatric clinical trials. Truly, until kind of the beginning of the new millennium, the way that pediatric dosing largely worked was like, oh, you're like 25% of an adult.
Right.
Whereas any of the kind of physicians or nurses in the room know that, of course, that is not accurate. A child and an adolescent's biology and physiology is quite distinct. And so I put that into this kind of important conversation that kind of Chanel is leading at the moment, because I think, too, we sometimes, we don't forget, but we haven't again yet been taught that so much of medicine has been built on and centered on white men.
Yes. Yep.
And so I think often in a conversation about implicit biases, there is the implicit assumption that those are somehow less pernicious. But often the implicit biases are the result of quite explicit structures that were built over generations. And yet we have to kind of name them and address them and kind of teach and heal our way out of them, and really, through that process, be led by kind of Chanel and others who are centering their communities and appropriately themselves. If we are, though, not mindful of all the antecedents that led us here, we are not going to be able to do that.
And speaking of the antecedents, we are about to mark the 1-year anniversary of Roe v. Wade being overturned. We are having this conversation against that backdrop. What is remarkable is that the studies are still being done about the impact, and it's very early on because it's been a year. But there is one study by Boston University and the Commonwealth Fund that shows that states have restricted access to abortion rights have seen death rates that are 62% higher than states that preserve access to that service. Now, I've spoken to anti-abortion advocates about these numbers, and they say, hey, wait a minute. It's not fair because it's too early and we don't have a federal registry yet. But it has been a year. Chanel, reflect on those figures. I mean, how does that hit you to hear that? And because we want to talk about solutions, how do you get access to health care and to reproductive health care to women who live in states where abortion rights are restricted?
Yeah, so, it's very interesting. The same states that have these restrictions and these bans are also the same states that have high infant and maternal mortality rates already, right? They have people are living in maternal health deserts. They don't have access to
also the people kicking women off Medicaid right now.
Right. They're also the folks who are kicking folks off Medicaid. They don't have access to physicians. They don't have access to midwifery care. And so now you have a compounded issue, right, where now you're forcing someone's hand to carry a pregnancy to term. And when we think about it, right, what does it mean for us to not center someone in their reproductive life course? right? To be forced to carry a child to term, but maybe not necessarily have the social supports in place. So I think on one hand, it's one thing for you to say, oh, you need to have a child, but you also need to be able to have those social supports in place to be able to raise those children in healthy and safe and loving environments. And these environments of these states are not states where they are wanting to raise children in healthy, loving, and environments where they can survive and thrive. And I think some of the, when we're looking at this, we're looking at now people who have to transfer state lines. They're putting themselves at risk. They have to think about childcare. They have to think about where am I going to stay. They have to think about funds, all of these different things. Now, if you have the socioeconomic means, you're fine. Right? You can do it, no problem. But if you don't, then you find yourself, especially in some of these states where they have put in place laws where if you can tell on someone and say, hey, this person did this. Now, right, what are the consequences to that? And so we really have to, what we've started to do is really, luckily New York is a safe haven for folks. New Jersey is a safe haven for folks. And so you can come in and you can get care, right? But also physicians are afraid to provide care, right? And so most recently in New York, they passed a law where physicians can supply the necessary medication, they can support, and there are not going to be any repercussions for doing that care, right? But someone shouldn't have to go through all of that just to be centered in their reproductive health care. And so we find others who are trying to find amazing ways to really center folks in a very dangerous situation.
Chelsea, what are your reflections 1 year after Roe? And you've talked about the importance of partnerships in helping to reach people throughout New York and to address the crisis there around maternal mortality. But how do you help the people in these other states?
Kristen, you first asked, what was my reaction? I'm really fucking angry. And and that is an uncomfortable place to be because of the historical women tropes that so often have been used to kind of silence and diminish kind of women and our voices, not only in this country, but throughout human history. But I'm really angry because we know that women have died. And so it shouldn't matter that we don't yet have a federal registry. When you have families and you have physicians and you have midwives saying, this woman died because she was 4 days into sepsis because someone still judged that her fetus might be viable, and so they were worried about providing medically indicated necessary care, and she died? That isn't up for debate. That is someone who isn't here to be with her family and her friends and her community and to be part of our future. So I am angry because before Roe, we knew that about 200 women were dying every year because of botched abortions or the lack of access to medically indicated abortion care. We know that. That's not actually up for debate. And so we knowingly have moved forward, because we haven't gone back, we're in 2023, we have moved forward to, again, a time in which we are making women more vulnerable because of a very extreme, narrowly rendered view of Christian white nationalism. And we cannot afford to not be candid about what is happening. And also that movement has become so emboldened, it is more extreme now than it was even a decade ago. A decade ago, the model legislation that the forces of forced birthing in our country and anti-reproductive choice and anti-kind of public health evidence, the model legislation still included exceptions for rape, exceptions for incest, exceptions for the life and the health and well-being of the mother. And now those are largely gone in the 13 states that have passed effectively total bans and what's being considered in a number of other states. We are knowingly endangering women's lives. We are knowingly actually forcing women into dangerous and deadly situations because of a very slim minority's ability to control different state legislatures. And we have to be mindful of that. And we also, I think, have to stay angry and organized. Because we know, because we've seen it in Kansas and elsewhere, when people actually have the chance to vote, most Christians are still voting to protect a woman's right to health and well-being and choice and agency. So we just need to be very clear about where we are in this political moment. We need to not be dissuaded, because it is unacceptable to me that any woman would die when we actually know how to save her life, and also that any woman would not have her fundamental human right to be able to set the course of her own destiny.
On that powerful point, I do want to open it up to some questions from all of you, and then I want to let you all have some final thoughts. Sir, go ahead. You're in the front row. And just introduce yourself so we know who you are.
My name is Shachin. I'm a doctor and I run a healthcare organization in India. Thank you very much for such a brilliant panel, and thank you for driving all the way. Thank you so much. I just wanted to raise a small point that I felt the panel didn't touch upon. So yesterday, amongst the fellows' discussion, there was this feeling that US is slowly but surely withdrawing itself from its role as a world leader in healthcare. And we are just getting more and more inwards into ourselves here. You say that the MMR is unacceptably high in the US, which I agree. Even at 30 per 100,000 births, it's still, I think, 10 times what it could be if all the points that you raised here are enforced and executed correctly. But countries like ours, we're the largest country in terms of population. We still have MMR north of 100. And rapidly growing countries like Nigeria have MMRs north of 500. So what are your thoughts on whether the US should resume back its role as a world leader? Because if these countries do not meet the SDG targets, the SDG targets as a whole will definitely not be met, whatever we do. So what are your thoughts on that?
And to add to that, is the U.S. investing enough in other countries and their healthcare systems?
So thank you so much for your question. I think the United States is the largest single bilateral donor to global health around the world. And yet, of course, I think we need to be doing more, because if the last few years haven't shown how interconnected we all are, I'm not sure what other exemplar there could be. And so certainly, agree that we need to continue to fight for PEPFAR reauthorization, to kind of hold the line for the funds that we are investing, and continue to look to community leaders, similar to what Chanel was saying in an American context, around the world for what is working and what we should be helping to support. I do think it is quite hard, given where we are with our current maternal mortality crisis in this country, to have the moral standing to be leaders in that work. But I certainly believe that we could and should be partners in the work. Another related dimension to maternal mortality in so much of the world is the high prevalence of child marriage and adolescent and teenage births. We still have child marriage as legal in most states here. In the United States, it's thankfully legal in New York and New Jersey. Where we live, it's actually still legal here in the state of Colorado. So for any of you that are Colorado natives, write to your state legislators and governor about that. So I do think we just have to be mindful about where I think we have kind of resources and moral authority, like continuing to push for everyone everywhere to have early diagnosis and treatment of HIV, because we've done a pretty good job of that here, although not where we should be. And areas where, of course, we need to be doing more, but we don't have the same moral standing, like when it comes to maternal mortality, because of what we haven't done in this country, or what we actually purposely had disinvested in and moved away from in this country.
Yeah, I think it's a real opportunity for us to be humble and to learn from one another, right? Because we're not in a position of popularity, and take a stand where we can really understand what does it mean to center someone within their reproductive health. I have done work in Ethiopia and Uganda and have seen the ways in which maybe there's not this necessarily technology that's in place, right? Because here in the U.S., we have an overusage of technology. Like, it's totally overused when it comes to birth. And there, where they may lack a level of technology, what they do have is community. What they do have is a sense of networking, of resourcing, and a shared knowledge of learning from one another and really taking that and using that into place. And so I think we could really take an opportunity to learn from one another of what's working, what's not working, and really have a genuine cultural exchange.
Let's do one more audience question. Okay, since you're wearing a yellow blazer, you're up front. Go ahead.
Hi, thank you for being here, and thank you for what you are supporting in regard to women's health, women's reproductive health care. It's been very informative for me. I love being here, and I cannot believe y'all are here. This is just great. I'm Penry Gustafson, and I'm a Republican state senator from South Carolina.
Good.
And what I just wanted to add to the discussion a little bit. And I know personally how angry women are, specifically, and many others. It is a really tough situation for the state legislatures across the country because it is now in our hands to make those decisions. I might just add, because I'm a different kind of politician, okay? It's a pet peeve of mine, so this goes for anybody. But the word anger, just the word, and coming from it from that perspective, I think a better way needs to happen. I think we need to be calmer, especially for the people who really disagree. You'd be amazing. You'd be amazed at how many people I've talked to and listened to who totally disagree with me or vice versa. But until our nation and our legislators and our wonderful advocates calm down so we can actually transfer information, exchange it, and make better decisions, I just voted no against S-474. And it was a very, very tough thing. But I fought to get fatal fetal anomalies as part of the exceptions. And we have exceptions, and I will tell this room, anybody who else wants to know, the state of South Carolina, who's in the dead middle of the South, will never have a total abortion ban because the Senate will not allow that. The votes aren't there, and the 5 women of the Senate are fighting for the best legislation we can get. And we are not over. We're going through round 5, and it's right now with the state Supreme Court. So I thank you for all you do. The Clinton Foundation, I would urge the Clinton Foundation to do more work in America towards women's legislative health. Thank you for what you do. Y'all are amazing people.
Chelsea,
thank you so
do you
much.
want to respond to that in the tone and how we break through barriers to better communicate with each other on what are these really complicated issues?
Well, I think we contain multitudes. I think we've seen that here on the stage, where Chanel and I both have had a lot of hope for what is working and a lot of kind of energy and enthusiasm for continuing to center in and invest in what is working. I am angry, and I do think we often are like told that we can't be angry, and I do think the Republican women of the South Carolina state legislature and state senate have been incredibly heroic, and I think that is important to be acknowledged by people on my side of the political aisle too, and that we of course have to find common ground where possible, and to start there and build from there. I don't know if I've ever shared this publicly. I might have. When I was 12 years old, I was at a campaign event with my dad. He was running for president, as you may know. And I was off to the side of the event, and I had kind of wandered off. I didn't have Secret Service protection then. I was a pretty curious kid. We were somewhere in the South, and I had a group of people come up and start yelling at me about abortion, and then someone threw a bag of what they said was blood at me, and it thankfully fell at my feet. They said, like, this is what your parents are advocating for. And I was like, what is happening? Right? Like, what is happening? And why are you attacking a kid? And like, you're sort of pro-kids, but like, I'm 12. Like, what is going on here? So the reason I say that is I certainly agree that anger when it comes to kind of physical intimidation, anger when it comes to physical attack, anger when it comes to sort of decentering someone's agency is not helpful, it is not healthy, and it should not be acceptable or part of kind of the discourse of, I think, what most of us believe is so important in our country, to be able to even identify that common ground and then build from it. That being said, I am angry, and I'm going to own that anger, and I also, though, I'm going to focus on the hopeful part of my multitudes, because I agree that is more productive. So I'm not going to leave my anger at the door. I'm going to use my anger to fuel my hope.
Yeah.
Chanel, final comment, and then we're unfortunately, we're out of time, but final word.
I would just add that being hopeful doesn't mean that you're meek. Okay, and so I'm hopeful every single day as a Black woman living in America who is raising Black children. I have to be hopeful. I have to be hopeful in the humanity of every individual as my children go off into the world. I have to be hopeful that when I am working with someone that they're going to be centered and affirmed in their reproductive health access, but I'm also very diligent about making sure that people are seen, they are heard, and they know that they're genuinely cared for at the same time. And so while I totally understand, there's nothing wrong with anger. Anger is something that drives connection. It also moves us to be able to make changes that need to happen within our world. If people weren't angry, we'd still be in a place of despair, right? And so it's important for us to be hopeful in every moment and aspect of our day, but don't be meek. Don't stand for things that don't center you and don't center other people. Know that you have the opportunity to make a change in the most smallest of ways. A lot of times people feel like I have to have money, I have to do this, I have to do that in order to make a change. No, you don't. I started out in my house. Opening up my house to someone and to people, creating a safe space and feeding folks and listening. And from that, we have been able to make tremendous changes in the ways in which people are able to navigate into reproductive health spaces. So be angry, be hopeful, but never be meek.
Amen.
Right. And we'll leave it with that. Chelsea and Chanel, thank you so much,
Kristen.
Thank you all. Conversation. Thanks to all of you. Thank you all so much.
Thanks for watching our YouTube channel. Follow today's top stories and breaking news by downloading the NBC News app.